So axi-cel was approved for relapsed refractory follicular lymphoma. It's FDA approved actually for patients with relapsed refractory follicular lymphoma after 2 or more lines of treatment. And this is based on the results of the ZUMA-5 trial. So in the ZUMA-5 trials, the overall response rate was around 94% and the complete remission rate was 79%. Patient had toxicity, CRS and ICANS, and the rates of severe toxicity were around 6% for severe CRS and around 15% for severe ICANS. So in our abstracts, we proposed a novel composite endpoint of toxicity-free and progression-free survival at 6 months after CAR-T. And in this case, it was for patients with relapsed refractory follicular lymphoma who received axi-cel. So this TPFS, or toxicity-free progression-free survival endpoint, includes patients who had severe toxicity, including severe CRS and severe ICANS, and progression or non-relapse mortality within the first 6 months after of CAR-T. Our population of patients was a small population of patients. We had 21 patients. Most of these patients had severe baseline disease, so having more than 3 risk score in 62% of patients, and the median lines of treatment was around 4, so pretty heavily pretreated patients. In this population of patients, 12 among of 21 patients were toxicity-free, progression-free at 6 months after CAR-T, around 57%, and 9 patients had any toxicity and or progression within 6 months. The main causes of toxicity and progression were ICANS in 5 patients, 1 patient had CRS, and 3 patients had progression. No non-relapse mortality was observed in our cohort of patients. We tried to do a landmark analysis to evaluate the effect of this TPFS on progression-free survival, and so there was an improved progression-free survival in those patients who were toxicity-free, progression-free. However, this wasn't statistically significant. But we think this is related of the small cohort of patients and the limited event. We are now expanding this cohort and doing it on a larger population of patients with relapsed refractory follicular lymphoma. So we think this novel composite endpoint, since it includes the relevant clinical aspect of CAR-T, including both toxicity and efficacy at the same time, is a better way to evaluate response after CAR-T, and it allows us to better compare between CAR-T products because it includes both toxicity and progression. So the next questions for this novel composite endpoints are when to evaluate it, whether 6 months is the ideal endpoint, and it could be different for different diseases. So it could be 6 months for follicular lymphoma, but different for other aggressive lymphomas or for other types of hematologic malignancies. And also then the other questions were the CRS and ICANS sufficient as toxicities after CAR-T? Shall we include other comorbidities after CAR-T to better level up and improve this novel composite endpoint?